So, good evening, everyone. Yes. So, am I audible and visible? Yes. Am I audible, visible? And are we all ready for the class? Yes. 1 minute. Just give me a second. Yes. Huh. So, okay. So we will be considering MCQ today, basically in the form of lots of PYQs. And I'm your mentor, Dr. Reena. So if everything is clear, let's get started with the first MCQ. Yes, so let's get started. Now the first MCQ says, okay, the first MCQ says as, now this is in the form of a graph, okay, it is in the form of a graph. All okay? I'm audible, visible, is all okay? Yes. So see, this is one of the very favorite questions which very repeatedly come on, that is on the oxygen dissociation curve. So repeatedly you're going to get this question in the exam. Very favorite question. Right? Now, the question says that in the packed RBC transfusion, which of the following oxygen dissociation curves will be observed? Curve B, okay, curve C, this is supposed to be normal, curve D, or whether it is curve E, right? So which of the following is supposed to be the oxygen dissociation curve if A is normal? Now you must understand when the blood is packed, okay, what are the changes when the blood is packed and what are the changes when the blood is being transfused. All these points should be into your consideration. So the correct answer for this is curve B, that is, this is the correct answer, right? Now how do I justify that this is the correct answer? Now see, the left shift of the curve, that means the oxygen hemoglobin dissociation curve is shifted to the left when there were packed RBCs which were being given, right? Or where it is packed RBC or in the transfused blood. Now this occurs whenever the blood is packed, I mean when you are giving the blood before the blood bank or before the blood is being given into the individuals, and when the blood is just in the backpacks at the time of transfusion, just before transfusion. Remember that there is a decrease in the metabolism, okay, there is a decrease in the metabolic activity, and because of this what happens that there is a decrease in the level of 2,3 BPG or DPG, that is biphosphoglycerate levels or diphosphoglycerate levels. Normally you know that this 2,3 DPG, it binds to the beta chain of hemoglobin and shifts the oxygen hemoglobin curve towards right, that means it favors oxygen delivery. Okay, but in that packed blood, when the metabolism is reduced, Ishpreet, what will happen is that this 2,3 DPG levels will go down, and this is going to shift the blood, the hemoglobin curve to the left. That means making it harder for the hemoglobin to release oxygen. So when transfused, the stored RBCs have got diminished level of DPG initially, and this normalizes as the blood is transfused and it goes towards the patient's body. So it is not going to be a very permanent, it is a temporary phenomenon. Now if you analyze the other curves, as I've already told you that the curve A is normal. B, we've seen a left shift of the curve, which can be seen in other conditions also. That is, from apart from 2,3 DPG, you can also get it with hypothermia or alkalosis. And this condition is matching with packed RBC. And the curve C, which can be seen a greater left shift. This can be seen with extreme conditions of hypoxia or extreme decline in the PCO2 levels. Right shift of the curve, acidosis, increase in 2,3 DPG levels, increase in carbon dioxide or temperature. And a curve E is an extreme rightward condition. Now this curve is one of the most important image-based questions, or otherwise also it is important, where you must remember that at partial pressure of 60 mmHg, the person's saturation is 90%. This is one of the very, very important considerations, because as you move towards high altitude and the partial pressure of oxygen becomes less than 60 mmHg, the first sign of hypoxia occurs, because the person's saturation will become less than 90%, and that is going to stimulate your peripheral chemoreceptors. Right? Now, just remember, right shift to the right. Right means what? So this is my right. Right means more. R. What more? Increase in H plus, increase in temperature, and increase in carbon dioxide, and increase in 2,3 DPG levels. So right shift, that means oxygen delivered to the tissues. Left means decrease or less. What less? Same factors: hydrogen ion, carbon dioxide, temperature, and DPG. So right shift and left shift will always remain one of the most important questions in your examination. Now, moving on next. Hepcidin inhibits which of the following? Options: absorption of cobalamin, transfer of iron into enterocytes, folic acid synthesis, or respiratory oxidase. This is a very recent MCQ, and iron absorption remains very important. If you just go through your PYQs, many a time question is asked on iron absorption, the site, the factors affecting, etc. So here the correct answer is B, that is hepcidin inhibits the transfer of iron into enterocytes. Okay. Now see, what is hepcidin basically? So this hepcidin is basically a central regulator of iron homeostasis. Okay. It is a regulator of iron homeostasis. It is produced in the liver whenever there is increase in the level of iron or when there is inflammation. So this hepcidin is a peptide hormone produced by the liver, and it principally plays an important role in regulating your iron metabolism. And its main function is to inhibit the transfer of iron into bloodstream from the enterocytes, or from the hepatocytes, or from the macrophages. So remember, it is playing a very, very important role in your iron metabolism. This hepcidin, how does it act? It binds to ferroportin, right? It binds to ferroportin. Remember, I'll show you another figure where this ferroportin, you will see that it is an iron export protein which is present on the surface of the enterocytes. So when this hepcidin binds to ferroportin, it causes the ferroportin to be internalized, to be degraded, and thus it prevents the iron from coming out of the cells into the bloodstream, right? So it is preventing the excess of iron into the bloodstream. Ferroportin, the only known iron export protein which is present on the enterocytes, and also hepatocytes and macrophages. And this hepcidin inhibits its function to regulate iron release. So it is actually regulating your iron level in the bloodstream. Remember, other questions related are: the site of reabsorption of iron is duodenum. Now, what is the clinical relevance of this? This elevated hepcidin levels can lead to conditions like anemia, or anemia of chronic disease by limiting iron availability. So hepcidin, they are basically reducing the level of iron in the bloodstream, and therefore excess of hepcidin can be in the way not entertaining, because it is limiting the iron availability, so it can result in anemia of chronic disease. On the other hand, if the hepcidin levels are very, very low, it can result in iron overload. Okay, it can result in iron overload. So this is the figure which is showing you the absorption of iron. On the apical side, this is the very, very important protein that absorbs iron, which is the divalent metal transporter 1. Divalent metal transporter 1, the heme transporter or the heme carrier protein, and this is which is going to convert your ferric form of iron into ferrous. And this is on the basolateral side. You have the ferroportin, and associated with this you have got hephacetin. Okay, hephacetin. So this is not hepacidin, that is different. This is hephacetin, which is associated with ferroportin. So remember that this is present on the basolateral side, but DMLT is present on the apical side. So iron absorption is brought about by DMLT. Next, there is a patient coming with cold skin, fatigue, shortness of breath on exertion, and enlarged liver. On examination, the jugular venous pressure shows a prominent A wave. What is the most likely cause of this elevated A wave in the patient? Options are tricuspid regurgitation, tricuspid stenosis, mitral regurgitation, or mitral stenosis. So we are given the clinical history of cold skin, fatigue, and shortness of breath. Clinical examination, enlarged liver, and JVP shows a prominent A wave. So all these conditions, which are clinical as well as which are related to different signs and symptoms, should be coupled together, and you will see that the correct answer here becomes R, tricuspid stenosis. So the correct answer is tricuspid stenosis. This provides an important information. JVP, okay, the jugular venous pressure. See here you can see the normal jugular venous pressure, which gives you a reflection of pressure of the right atrium. A wave, C wave, and V are the positive waves, where A is because of atrial systole, C is the bulging of the tricuspid valve into the right atrium when there is isovolumetric contraction, and V is the venous filling of the atria. X and Y are negative waves, that means decrease in pressure in the right atrium, where X is in the period of atrial relaxation and Y is when there is filling of the blood from the atria into the ventricles. So the blood passes from the atria to the ventricles. The decrease in the blood volume also decreases the pressure. So this is the normal jugular venous pressure. And important information which we get is that this A wave is representing atrial contraction. So whenever there is an increase in the amplitude of the A wave, right? So whenever there is an increase in the amplitude of the A wave, that means there is something where the right atrium has got a resistance to increase contraction. Okay, so the right atrium has got an increased resistance to contraction, especially when it is pouring the blood into right ventricle. Right, so this is typically the case of tricuspid stenosis. Why tricuspid stenosis? This clinical condition is characterized by the narrowing of the tricuspid valve, and when this valve becomes narrowed due to stenosis, the right atrium faces an increase in the resistance while it has to push the blood through that narrow valve, and this causes an increase in the amplitude of the A wave in JVP. Now looking into the other options, that is tricuspid regurgitation. Now in tricuspid regurgitation, the tricuspid valve is not closing properly, right? This allows the blood to flow back from the right atrium into the right ventricle even when the ventricles are contracting. So this condition is going to actually result in an absence of the A wave but a prominence of the V wave in JVP. Right, absence of A wave and the prominence of V wave in JVP. We also can rule out mitral regurgitation and mitral stenosis, because mitral regurgitation means involving the left side of the heart, when the mitral valve allows the blood to leak backward into the left atrium during left ventricular contraction. So this is not going to cause A wave, definitely, because A wave is dealing with the right atrium. Similarly, mitral stenosis, when there is narrowing of the mitral valve between the left atrium and the left ventricle, again, this is impacting the left side of the heart. So we cannot expect a prominent wave which is dealing with the right side of the heart. So in this way, we rule out the other options. Okay, so in this way we rule out the other options. Okay. Now let's move on next. So this is typically giant A wave. Now remember that this particular question is important both in physiology as well as in your medicine. This can come in the form of a clinical question like what we have framed, plus it can also be in the form of an image based question. Now again, a very important question that is related to our general physiology. There is a body fluid compartment which is showing sodium 10 milliequivalents per liter, potassium 140, chloride 15. So based on these values, you have to tell us that what is this compartment being asked about, whether it is your interstitial fluid, ECF, ICF, or whether it is plasma. So ये कौन सा compartment है, that is to be reflected by your answer. So just look where you see that the potassium concentration is found to be more, whereas the chloride and the sodium concentrations are less. So definitely our answer will be ICF, because sodium is predominantly present where in the ECF, that is around 135 to 145 milliequivalents per liter, and such low sodium concentration gives us an idea that this is definitely ICF and not ECF. So this is in the form of a figure where you can see that we have seen the major anions and cations. Okay. If there's any problem, you can text me if there's any problem. So you can see that this is the ECF where the major cation, okay, where the major cations are sodium. Even calcium is more in the ECF, right? And the major anions in the ECF are chloride, or it is chloride. And if you look over to your ECF, the major cation is potassium. Magnesium is more in the ICF. And remember that the major anions which are present in your ICF are inorganic phosphates and protein is the most important intracellular buffer. Now, there is a young patient with muscle spasm. Okay, a clinical history of a patient with muscle spasm, numbness in the hand and feet, seizures, difficulty in breathing due to laryngospasm. His blood work reveals an electrolyte imbalance. What is the most likely cause of these symptoms or manifestations? So muscle spasm hai, numbness hai, seizures hai, right? Seizures is very, very important, and this question is associated with your acid-base balance. Options are respiratory acidosis, alkalosis, or whether it is metabolic acidosis or alkalosis. So the correct answer over here is respiratory alkalosis. Now why? What are the symptoms? Muscle spasm, numbness, seizures, laryngospasm, and all of these favor hypocalcemia. This hypocalcemia is over here due to respiratory alkalosis. Now what happens that when there is respiratory alkalosis, there is a decrease in the ionized calcium levels in the blood. So when there is alkalosis, what happens? The protein which is present, okay, see, this is the protein which is present in the body. Normally these proteins can bind to H plus ions. Okay, they can bind to H plus ions, and the calcium remains free. Okay, the calcium remains free, or it is present in a sufficient quantity in your fluids. Now when there is alkalosis, that means when there is a raised pH, that means when the hydrogen ions are not in sufficient amount or they have decreased. So यहाँ पे जो हाइड्रोजन था पहले, okay, जो पहले हाइड्रोजन था, that will be now taken up by calcium. So the proteins are now going to bind to the ionized calcium. So what will happen? The level of calcium would reduce, and this would result in the symptoms of muscle spasm, numbness, or laryngospasm. And you know that hypocalcemia results in an increase in the neuromuscular excitability, because calcium normally covers the sodium channels, and what does it do? It does not allow the sodium channels to open up at any potential. So potassium, it allows, or it guards the sodium channels and do not allow them to open at any change in the membrane potential. So they will open only at a threshold potential. So respiratory alkalosis, where there is excessive breathing, that is hyperventilation, resulting in carbon dioxide washout. The carbon dioxide washout is responsible for alkalosis. This alkalosis, that means when there is a decrease in the H plus ions, will favor the calcium to bind to albumin. Because the calcium binds to albumin, the free ionized calcium in the blood goes on decreasing, and that is the reason that where the feature of respiratory alkalosis will result in numbness or tingling or tetany. Right? So this is a beautiful, a chart where you can see that metabolic acidosis decrease in pH, and the cause will be decrease in bicarbonate, right? And the compensation will be by reducing your carbon dioxide level. Metabolic alkalosis, rise in pH, cause is increase in bicarbonate, compensation is by increasing CO2 levels. Respiratory acidosis, decrease in pH, but respiratory acidosis means the cause is going to be carbon dioxide. So rise in carbon dioxide, which will be corrected by increase in bicarbonates. So you can see that the first step in classification of acid-base disorder is look into your pH. Second is look into bicarbonates. So when the pH and the bicarbonates are in the same direction, it is metabolic condition. But when the carbon dioxide level is elevated, it would be respiratory acidosis. If the carbon dioxide level is reduced, it would be respiratory alkalosis. Compensation is going to be given either by kidneys or by respiratory system. Now, anion gap, if you want to understand, remember that anion gap, we assume that in the body, the total cations is equal to the total anions. That means we consider that sodium is equal to chloride plus bicarbonate, and the total anions or the anion gap is in the range of 8 to 16 milliequivalents per liter. And we are not considering the unmeasured anions. Right, so whenever we are measuring the cations or anions, we are only thinking about the measurable one. We are not considering the unmeasured anions and cations. So when these unmeasured anions will increase, that is going to result in your anion gap. So when there is an increase in the anion gap, okay, increase in the anion gap, it can be either with a normal chloride or it can be a normal anion gap with increase in chloride. Now, what do you mean by this? See, anion gap is only in the condition of metabolic acidosis. Okay, you consider this only in the condition of metabolic acidosis. So in metabolic acidosis, there is a decrease in the bicarbonate level, right? And to compensate for this, what will the body do? To compensate for a decrease in the anion, the body will increase other anions. These could be either chloride. If there is increase in the level of chloride which is normally a measured anion, ठीक है, उसको हम normally measure करते हैं. So whenever there is a decrease, okay, so whenever there is a decrease, whenever there is increase in the chloride ions with metabolic acidosis, it is always going to be a normal anion gap. ठीक है, मतलब जब बाइकार्बोनेट्स डिक्रीज हुए और उसको कॉम्पेंसेशन के लिए जो आयन बढ़ा वो क्लोराइड है, एंड क्लोराइड इज एन आयन विच हम नॉर्मली मेजर करते हैं, वो नॉर्मल एनायन है जो हम लोग मेजर करते हैं. ठीक है, सो इसमें क्या होगा, देयर विल बी मेटाबॉलिक एसिडोसिस बट द एनायन गैप विल बी नॉर्मल, like diarrhea, renal tubular acidosis. Lekin if there is a decrease in the bicarbonate ions in metabolic acidosis but the chloride remains normal, if the chloride remains normal, that means then that there is some other anion, there is some other anion which is increased, it is not a chloride. तो जब क्लोराइड आयन नॉर्मल रहेगा और अदर एनायन बढ़ेगा, देन ओनली यू आर गोइंग टू गेट एन इंक्रीज इन द एनायन गैप. वेरी कॉमन कॉज इज डायबिटिक कीटोएसिडोसिस. ठीक है, वेरी वेरी इंपॉर्टेंट इज दैट डायबिटिक कीटोएसिडोसिस. Now next, what is the sequence of events after P wave? This is again a very very important question. This is a kind of a sequence based question which you are getting nowadays of cardiac cycle, right? A wave, first heart sound, rapid filling of the ventricles, and P wave. So what is the sequence of events after P wave? The correct answer is A, that is A followed by C followed by B and followed by D. ठीक है, now let's understand this. Now, remember when we speak of our cardiac cycle, okay, when we speak of our cardiac cycle, there is going to be electrical events, that is the changes on ECG, which is the first thing that's going to occur. ठीक है, after the electrical events, you're going to get mechanical events, that is your systole and diastole, and these are actually then resulting in your pressure and volume changes. So first there is going to be atrial depolarization on the P wave followed by atrial systole. ठीक है, so the sequence will always begin from the electrical events. So we know that the P wave on the ECG is what? Atrial depolarization, and therefore the first wave which you are getting is the P wave, which is going to trigger atrial contraction. After the P wave, what do you get is A wave. So what is the cause of A wave? Atrial systole. So the P wave on ECG is going to be followed by A wave on JVP, because P wave is atrial depolarization and A wave is atrial systole. ठीक है, and A wave is atrial systole as reflected on your JVP. So P wave causing atrial depolarization, and then there will be contraction of the atria and it will produce your A wave. Now, the first heart sound occurs with the closure of the mitral and the tricuspid valve, that is the beginning of the ventricular systole. Now remember the last part, okay, the last part of the ventricular filling, the last part of the ventricular filling coincides with the atrial systole. That means as the blood will come from the atria into the ventricles will close their AV valves, and that is going to mark the onset of isovolumetric contraction. That means there's going to be S1, that is the closure of the mitral and the tricuspid valve, or the beginning of systole. Now after this isovolumetric contraction, what is going to happen? There's going to be onset of systole and then diastole. अब यहाँ पर हम लोगों को डायरेक्टली जो वेव दी थी वो टी दी थी, इसलिए टी वेव लास्ट आएगी, बिकॉज टी वेव का मतलब होता है वेंट्रिकुलर डीपोलराइजेशन, है ना, वेंट्रिकुलर सॉरी वेंट्रिकुलर रिपोलराइजेशन, QRS इज वेंट्रिकुलर डिपोलराइजेशन, बट हमको यहाँ पर QRS दिया ही नहीं है, हमको क्या दिया हुआ है ऑप्शन में, टी वेव, इसलिए टी वेव विल बी द लास्ट, दैट इज वेंट्रिकुलर रिपोलराइजेशन. Therefore the sequence is ACBD, ACBD, A, C, B and D. Okay, अब इस सेम चीज को let us see over our Wigger's diagram. This is called as your Wigger's diagram, one of the very very important image based question. देखो, now you can see that this is the P wave of AC, P wave on ECG. So see the P wave on ECG, that is atrial depolarization. ठीक है. Now this is going to set the atria into contraction. As the atria is going to set into contraction, the blood is going to go from the atria into the ventricles. As the blood go from the atria into the ventricles, here is the point where the AV valves will close. ठीक है. As the AV valves will close, there is beginning of isovolumetric contraction. So closure of the AV valve means beginning of the isovolumetric contraction, that is the ventricular systole, but this is going to be preceded by QRS complex, okay, by QRS complex on the ECG reflecting ventricular depolarization, and that is going to be time we are going to get the first heart sound, that is S1 on phonocardiogram. So this is the way you have to correlate this figure. Now as the pressure, see momentarily for a very short time the pressure of the left ventricle will become more than that of the aorta. ठीक है, the pressure of the left ventricle in red will become more than that of the aorta. This is the black dotted line. That means that is the period when the valves will open, the aortic valve will open and the blood will eject. So this is ejection. As there is ejection, there is a fall of pressure, and this is the point where there is the closure of the aortic and the semilunar valve, and this reflects the S2. So you can see यहाँ पर directly S2 मिलेगा, उसके just पहले you're going to get ventricular repolarization, that is T wave on ECG. So you have to learn the cardiac cycle sequence based. Now next is the slow waves on the basic or the basic electric rhythm. Okay, the slow waves or the basic electric rhythm are least in stomach, duodenum, jejunum or ileum. So what is the correct answer? The correct answer is A, that is stomach. So remember, these slow waves which you get in your GIT, which is also called as the basic electric rhythm, are not generated by any they are what we called is that they are supposed to be the pace, they are generated by the pacemaker cells, the interstitial cells of Kajal, interstitial cells of Kajal. So that means they are not brought about by the enteric nervous system or the gut brain. They are not brought about by the enteric nervous system. They are caused by the brought about by the interstitial cells of Kajal, which are supposed, Kajal C, which are supposed to be the pacemaker cells, and they have got different frequencies throughout the GIT, and they are supposed to be least in the stomach, around 3 cycles per minute. Remember that they are not true action potentials. Okay? They are not true action potentials. They are highest in frequency in the duodenum, that is 12 per minute, jejunum around 10 to 11 and ileum around 8 to 9 per minute. So when these slow waves are superimposed by an electrical activity or by the burst of action potential, so suppose you have eaten something, or suppose there is release of acetylcholine, okay, or suppose there is distension or any factor which is stimulatory to the gut, and these slow waves will be superimposed by these electrical activity which will generate the action potential, but these themselves are not true action potentials. Okay? These themselves are not true action potentials. Now this you must remember that this figure is migratory motor complexes which are supposed to be interdigestive movements. Okay, they are supposed to be interdigestive movements which occur every 90 minutes. Okay, which occur every 90 minutes, and they are supposed to be the housekeeper waves. Okay, they are supposed to be the housekeeper waves. So when you eat, immediately after you eat, that means in the well-fed condition, what we get in the well-fed condition are peristalsis. ठीक है, peristalsis. But interdigestive period में जो आपको मिलते हैं, that are MMC, that traverse all the way from the antrum to the ileum to clean the GIT and make it prepare for the next meal. And the cause of this is again not the enteric nervous system but the hormone mortallin. Now, the concentration of all of the following decreases in the PCT except amino acid, glucose, chloride, bicarbonate. Obviously, the correct answer is chloride, because if you look into your PCT, the first half of the PCT itself is going to absorb sodium with glucose with the help of SGLT2 cotransporter, and 100% of glucose is going to be reabsorbed in the PCT. Also, sodium is going to reabsorb amino acids, and also there is a reabsorption of bicarbonates, which is called as an indirect reabsorption of bicarbonates in the PCT. So when you go towards the end of the PCT, the concentration of chloride would be increased, because chloride reabsorption is not favored in the first half. Sodium is very busy in reabsorption of the other compounds. So in the second half, you get something very interesting. Because of the increase in the chloride concentration, you get something which is called as the chloride driven sodium reabsorption. Chloride driven sodium reabsorption. क्यों? क्योंकि second half of PCT में the chloride concentration is more and it is going to drag sodium. Now, so amino acids 100%, glucose 100% reabsorption in the PCT. Now, what happens when the person stands from a supine position? Again, very interesting question. So as suppose the person is supine and immediately he is standing. What are we expecting? Because of the effect or the change in the posture, there is going to be venous pooling of blood, right? So momentarily a decrease in the flow of blood towards heart, which can bring about a probability of a fall in blood pressure. So this fall in blood pressure is immediately sensed by your baroreceptors, because the baroreceptors are very, very important in the rapidly regulating blood pressure mechanisms, which is neural. It is an example of negative feedback mechanism. ठीक है? Abhi, what are you now expecting when I have told you the physiology that there is going to be a decrease in blood pressure? So what are you expecting? There would be increased firing or a decreased firing in the baroreceptors. The vagal output to the cardiac fibers will increase, or both B and C. What are you expecting? You can even answer if you want. If you want, you can even answer. Okay? Now, so remember that I told you that there is a probability of a fall in blood pressure. Now these baroreceptors, these are pressure receptors, mechanosensitive. Okay, they are mechanosensitive. That means they respond to stretch. Okay, they respond to stretch. That means when the blood pressure will rise, okay, when the blood pressure will rise, they will stretch. And there will be increase in the firing rate of baroreceptors. ठीक है, there would be increase in the firing of the baroreceptors. लेकिन जब blood pressure decrease होएगा, okay, when there will be a decrease in the blood pressure, what will happen? the fall in the blood pressure is going to result in the decrease in the stretching of baroreceptors or a decrease in the firing of the baroreceptors. Therefore, the correct answer is B, that is a decrease in the firing of the baroreceptors. So just don't confuse this, and you always have this notation in your mind that the baroreceptors, they keep on increasing their rate of discharge. It is not like that. When there is increase in the pressure, they get stretched and the rate of firing increases, or there is depolarization, or there is increase in the delivery of action potential. But when there is a fall in blood pressure, there is a decrease in the stretching, and that is going to result in the decrease in the firing or a hyperpolarization of baroreceptors. So be very, very clear with this. Okay? So you can see that baroreceptors are present in the carotid sinus and in the aortic sinus, supplied by 9th and 10th nerve respectively, and the center who mediates is the nucleus tractus solitarius, which is present in the medulla. This is also the MCQ. Now, the areas which will be controlled by this would be, now when there is a fall in blood pressure, what you have to do when there is a fall in blood pressure, you have to rise the BP. And if there is a rise in BP, obviously you're going to bring about a fall in blood pressure. That means accordingly you will either stimulate the sympathetic and inhibit the parasympathetic, or vice versa, right? So when the sympathetics would be stimulated, for example, when there is a fall in blood pressure, there is going to be stimulation, or it is going to act on the arterioles to increase or to bring about arteriolar vasoconstriction and venoconstriction. So whenever there is arteriolar vasoconstriction, there is increase in the total peripheral resistance, contributing to increase in the diastolic blood pressure. When there is venoconstriction, what happens when there is venoconstriction? There is an increase in the venous return to the heart. So increase in heart rate, increase in cardiac output, increase in systolic blood pressure. और एक बात also भी ध्यान रखना कि sympathetics also act upon the adrenal medulla, and what do they do is they increase in the release of catecholamines. So they bring about a very widespread effect on heart, on periphery and adrenal medulla. ठीक है? और अगर आपको blood pressure बढ़ाना है तो you're going to inhibit the parasympathetics. That means you're going to decrease the vagal output. So when you're decreasing in the vagal output, automatically the heart rate will increase. So this is very, very important question, baroreceptors. But remember that they are rapidly adapting receptors and they respond to mean blood pressure. Now, high anionic gap is seen in all except. So we've already covered this. So I think we should not repeat this, right? So high anionic gap is seen in diabetic ketoacidosis, lactic acidosis and renal. So exception would be respiratory. So we will not discuss this because we've already covered this. We can go with other question. Now, yeah, the macula densa is located in PCT, Bowman's capsule, distal convoluted tubule or glomerular capillaries. So densa, D, that is distal convoluted tubule. So what is macula densa? Macula densa is the part of the juxtaglomerular apparatus which is present just where the thick ascending limb of the loop of Henle, okay, just where the thick ascending limb of the loop of Henle is going to become the distal tubule, okay, just where the thick ascending limb of the loop of Henle is going to become the distal tubule, okay, and it is just near its own glomerulus. It is near its own glomerulus. What are the cells which are present? So the first cells which are present are macula densa, that is D, which are modified cells of the distal tubules or the DCT, distal convoluted tubules. These macula densa cells, they behave as chemoreceptors and they are also called as sensors because they can sense NaCl. Okay, and they play a very, very important role in the tubuloglomerular feedback mechanism. Tubuloglomerular feedback mechanism, that is very, very important to regulate your GFR. Okay, to regulate your GFR. Then the other cells which are present are the juxtaglomerular cells, which are also called as the granular cells, which are modified smooth muscle cells. Okay, they are modified smooth muscle cells of afferent arterioles, modified smooth muscle cells of afferent arterioles, and they secrete renin. And you have got mesangial cells, which are a kind of a plugging device between these two cells. Now remember, these are also called as extraglomerular mesangial cells. They are called as extraglomerular mesangial cells, right? So they are, because there is specific intraglomerular mesangial cells also, but they are not the part of juxtaglomerular apparatus. Only the extraglomerular mesangial cells. Intraglomerular are between the basement membrane and the endothelial cells, which have got totally different function. They are contractile in nature and they can regulate GFR. So extraglomerular mesangial cells are a part of juxtaglomerular apparatus. Now you know that this renin will act as an enzyme, okay, and it will convert angiotensinogen to angiotensin 1, which will be converted by angiotensin converting enzyme, that is ACE, coming from the lungs into angiotensin 2, which can also be converted to 3 and 4. But angiotensin 2 is a very, very potent vasoconstrictor. Okay, it is a very potent vasoconstrictor. It causes secretion of aldosterone from the adrenal cortex. It also helps in the sodium reabsorption from the PCT, and it also helps to increase thirst. Okay, by acting on the centers which are outside the blood-brain barrier. The most important stimuli for the renin secretion are prostaglandins, increase in the sympathetic activity, and catecholamines. And they are inhibited, or the renin secretion is inhibited when there is already increase in the NaCl delivery to macula densa. Because whenever there is a decrease in the NaCl delivery to macula densa, that causes the macula densa to sense that the NaCl is less, and it will then tell the juxtaglomerular cells to secrete renin. Okay, so it is going to signal the juxtaglomerular cells to secrete renin. And the conditions which cause renin secretion, ये तो factors हो गए ना, तो conditions रहेगी decrease in sodium, hypotension, hemorrhage, upright posture, dehydration, diuretics, to be remembered. Now calculate the respiratory quotient, where the value of oxygen is 250 ml and carbon dioxide is 200 ml. Now this seems to be very simple, because this seems to be very simple, but if you don't know the formula for it, you will make it wrong. So the calculation based questions are usually put not to check your maths, but to check whether you know about the correct formulas. And there are many calculation based questions in physiology. Now we know that respiratory quotient is carbon dioxide released to oxygen consumed. Therefore, it will be 200 by 250, that is 0.8. Remember, it is 0.8 on a mixed diet. Okay, 0.8 on a mixed diet. And you must remember, it is around 0.7 with that rich in fat. And if asked what is the respiratory quotient of brain, it is nearly 1, because the brain uses exclusively glucose for its metabolism. Now, which of the following statements are true regarding the skeletal muscle contraction? Extracellular calcium not important for contraction. Calcium released from mitochondria. Calcium released from sarcoplasmic reticulum, or both A and C are correct. So the correct answer is A and C are correct. Now let's understand this. Okay. Now, if you remember that this is the sarcotubular system where there are long, thin T-tubules in the skeletal muscle and your cisterns, that is the L-tubule. Okay, so you've got L-tubule, T-tubules, and again another L-tubule which will form a triad. Okay. These L-tubules or the cisterns are the storehouse for calcium in the case of skeletal muscle. Skeletal muscle is not at all dependent for calcium from any ECF source, which is true for smooth muscle and cardiac muscle. So smooth muscle and cardiac muscle. Smooth muscle and cardiac muscle, they are dependent on the ECF calcium. When the ECF calcium will come, that will bring about the release of stored calcium, but this is not the case with skeletal muscle, which totally depends upon the calcium that is coming or that is stored here within the sarcoplasmic reticulum. So very important thing to be considered. Second important difference is, you remember that यहाँ पर you have got DHP receptors on the T-tubules and यहाँ पर you have got ryanodine receptors. Now in the case of skeletal muscle, these DHP receptors are only behaving as voltage sensors. Okay, they are only behaving as voltage sensors. That means they are not releasing calcium, and as the action potential travels, it opens this DHP receptors by a mechanical configuration, okay, by a kind of a mechanical configuration or a lock and key phenomenon, okay, a lock and key phenomenon. This will ultimately result in opening of the ryanodine receptors and the calcium ions will be released. Okay, and these calcium ions will then bind to the troponin C, and then the muscle contraction will be initiated. Okay. But what happens with cardiac muscle? In the case of cardiac muscle, as the action potential travels and opens these T-tubules, DHP receptors, they will pour out calcium. That calcium will then result in the opening of the ryanodine receptors and release more calcium. So in the cardiac muscle, it is called as calcium induced calcium release. Okay, calcium induced calcium release, calcium induced calcium release. लेकिन skeletal muscle में these DHP receptors are core or pure voltage sensors. They do not release any calcium. So this is the basic difference in skeletal muscle and cardiac muscle. हाँ, मैं बाद में बात करती हूँ, थोड़ी देर बाद. Now, what factors contribute to, okay, what factors contribute to the latent period in a single muscle twitch? Very simple. Remember, we do this also when we do our graph related practicals or the amphibian practicals in your first MBBS, है ना? But उस समय we don't give importance to the graph. हम लोग को लगता है कि ये नहीं आते हैं, but ये आते हैं, ऐसे question आते हैं. So you give a stimulus, suppose this is the point of stimulus, and from the beginning period or the beginning of contraction, this is what is our latent period. So what are the causes of this latent period? Options are excitation contraction coupling, time interval from the point of stimulus to the onset of contraction, neuromuscular junction transmission, or transfer of calcium back into the sarcoplasmic reticulum. Obviously the answer is very, very simple. It is A, that is 1, 2, 3. So it is a time interval between the point of stimulus to the onset of contraction. This latent period will include everything. That is the process which is involved in the excitation contraction coupling and neuromuscular transmission. Now, calcium reuptake is a part of relaxation and it is not at all relevant to your latent period. So it is excluded from there. Now, which of the following factor helps to decrease the glomerular filtration rate? Okay, which of this decreases the glomerular filtration rate? This is again a very, very important question which is related to the forces that are acting to increase or to decrease your GFR, which we called as the Starling forces. Remember, there are two forces, hydrostatic and colloidal osmotic. Hydrostatic are pushing forces and colloidal ones are pulling forces. Okay? Now, so there is hydrostatic pressure at the glomerular capillaries. See, hydrostatic pressure at the glomerular capillaries. So it will push. That means it will increase GFR. Then there is hydrostatic pressure at the Bowman's capsule. So this is again going to push. Therefore, if you increase the hydrostatic pressure of the Bowman's capsule, it will decrease your GFR. Then you have got colloidal osmotic pressure. Colloidal osmotic pressure is because of the proteins which are present. So it is a pulling force. So if you increase, right, if you increase the colloidal osmotic pressure in the glomerular capillaries, it will decrease GFR. For example, there is a decrease in the renal blood flow. There is a severe constriction of the efferent arterioles. Or there is increase in the plasma protein concentration. And physiologically, there is no colloidal osmotic pressure at the level of Bowman's capsule. What is the reason? The reason is that normally no proteins are freely filtered and they do not come into the Bowman's capsule. So this colloidal osmotic pressure at the level of Bowman's capsule would be 0. Okay? It would be 0. Physiologically, this is not present. Okay? Now, so what was the question? What will decrease the glomerular filtration rate? So we are now clear that if you increase the hydrostatic pressure of the Bowman's capsule, the GFR will decrease. Remember, it is a back pressure which can be increased whenever there is a calculi in the ureter or in the bladder, which will increase the backward force or the hydrostatic pressure and decrease GFR. Right? So net filtration forces is equal to favoring force minus opposing force. The only favoring force is the hydrostatic pressure of the glomerular capillaries, which is 60 mmHg, minus the opposing, that is colloidal osmotic pressure of the glomerular capillaries and hydrostatic pressure of the Bowman's capsule, which contribute to 32 plus 18, and therefore the net filtration pressure across the glomerular capillaries is 10 mmHg. GFR is equal to net filtration pressure into Kf. Kf is filtration coefficient. This filtration coefficient depends upon hydraulic conductivity, that is, it depends upon the surface area of capillaries. It depends upon the surface area of capillaries and the permeability. So, if there is, kinking of the capillaries, when there is contraction of the intraglomerular mesangial cells or the stellate cells, the GFR will decrease, right? Now, static two-point discrimination is assessed by which of the following receptors? Now, once you get this word static, you must be very, very clear. There should be no confusion to you. अगर आपको static बोल दिया है, ठीक है? If you are given static, then you must be very clear. Yes, that static means what? Now, there are two types of receptors, if you know. Phasic or the rapidly and the slowly adapting receptors. Phasic and tonic, or the rapidly adapting receptors and the slowly adapting receptors. दो हैं आपके, है ना? So options are Merkel's disc, Meissner's corpuscles, Pacinian corpuscles, or all of them. So once you are given static 2-point discrimination, it means it is Merkel's disc. The reason is that Merkel's disc are slowly adapting receptors. ठीक है? They are slowly adapting receptors. They are not adapting fast. They are slowly adapting receptors. ठीक है? Especially for fine touch and static pressure. What is 2-point discrimination? You know, there is something which is called as a compass aesthesiometer, like this. And this helps you to detect the minimum distance which is required for any area to perceive it as a single stimulus or 2-point. So यहाँ पे tip of the fingers, lips, in these areas there is overlapping, lots of overlapping of the sensory modalities are overlapped. So वहाँ पे the minimum distance, okay, the minimum distance which the person can perceive as 2-point is as low as 2 to 2.5 mm. So because of lot of the sensory modalities, even itna chota sa distance can be perceived as 2-point. Lekin over the back, where the sensory modalities are comparatively less, a very huge distance around 60 to 70 mm is required to perceive the points as 2-point. This becomes the basis of what we called as our Braille script. Braille script are like these, है ना? ऐसे हैं. So the minimum distance the person can perceive and perceive and appreciate is just less as 2 to 2.5 mm. So this is the physiological basis of your Braille script. See, this is how is the 2-point discrimination with the help of the compass aesthesiometer. So you can see that the most superficial ones are the free nerve endings, Meissner's and the Merkel's corpuscles. Meissner's corpuscles are supposed to be rapidly adapting touch receptors. Rapidly adapting touch receptors. Meissner's. Merkel's are static or the slowly adapting touch receptors. Okay. In deeper you have got Ruffini's corpuscles and Pacinian. Out of this, Pacinian is again a rapidly adapting and Ruffini is a slowly adapting receptor. Free nerve endings are important for your pain. They mainly behave as nociceptors. So Merkel's fine sustained touch is important, whereas Meissner's light touch, dynamic, rapidly adapting, okay, like flutters, movement. Pacinian, vibration, rapid pressure changes. Now, which of the following is correct about physiological dead space? Inadequately ventilated alveoli, inadequately perfused alveoli, less than anatomical dead space, or can be measured by spirometry. ठीक है? Now, उसके पहले, before we come to the correct answer, just to recall you about dead space. What is dead space? Any space where there is no exchange of gases. ठीक है? Any space where there is no exchange of gases. Now, in your respiratory tree, which is given by Weibull model, okay, which is given by Weibull model, trachea से लेकर terminal bronchioles तक, okay, from trachea to terminal bronchioles, that is from 0 to 16th generation, उसको generations में divide किया गया है. This is supposed to be our conducting zone. That means it will only conduct the air, it will not participate in exchange of gases, and therefore it is called as the anatomical dead space. Anatomical dead space. Now the other from 17th to 23rd generation, this is supposed to be your respiratory zone where exchange of gases will take place. ठीक है? So this is anatomical dead space from 0 to 16th generation, or the conducting zone, which is 150 ml. The other dead space is alveolar dead space. अभी anatomical dead space is absolutely normal, which is present in each and every individual. सब में ये present होता है, that is anatomical dead space 150 ml. Alveolar dead space तभी present रहेगा जब there is ventilation perfusion mismatch. That means alveoli which are either not ventilated, obstruction to airways, or the perfusion is affected. For example, embolism, है ना? तो ऐसी conditions में you're going to get alveolar dead space, जो कि pathological है और कभी नहीं मिलती है. And what is physiological dead space? Physiological dead space is the total dead space. Total मतलब anatomical plus alveolar. But normally you can say that physiological dead space is equal to only alveolar dead space, only anatomical dead space. So normally physiological is equal to the anatomical dead space, है ना? Because alveolar नहीं रहेगा जब तक कि abnormality नहीं है. अब दूसरी बात, this is your alveoli, ठीक है? And when we speak of ventilation perfusion ratio, it is not uniform, क्योंकि the lungs are subjected to gravity, and therefore because of the effect of gravity, the basal portion of the alveoli are better perfused, and the apical portion of the alveoli are better ventilated. ठीक है? Better ventilated. Therefore the ventilation perfusion ratio is more over here and comparatively less over here. अब याद रखना एक और बात कि यहां का जो ऑक्सीजन और कार्बन डाइऑक्साइड रहेगा, it will be same as that of the atmosphere. That means around 140-150 oxygen and 0 carbon dioxide, because we are not inhaling carbon dioxide, or very less amount of carbon dioxide. So the oxygen and the carbon dioxide in the apical part of the lung, which will be same as that of the inspired air. ठीक है? क्योंकि MCQ आता है. पर basal portions में the oxygen and carbon dioxide will be same as that of the venous blood. बिकॉज यहां पर सर्कुलेशन कौन सी है? पल्मोनरी ब्लड फ्लो. और पल्मोनरी सर्कुलेशन में क्या होता है? वीनस ब्लड फ्लो, है ना? सो ऑक्सीजन कार्बन डाइऑक्साइड 40-45 mmHg वो वाला. सो अपाइकल में आपको मिलेगा ऑक्सीजन कार्बन डाइऑक्साइड जैसे इंस्पायर्ड एयर है, और बेसिस में आपको मिलेगा ऑक्सीजन कार्बन डाइऑक्साइड जो कि वीनस ब्लड का है. ठीक है? नाउ विद दिस इन माइंड, द करेक्ट आंसर बिकम्स true about physiological dead space is B, that is inadequately perfused alveoli. Inadequately perfused alveoli, right? So physiological dead space is equal to anatomical dead space plus alveolar dead space. ठीक है? You can calculate dead space by two methods. So physiological dead space can be calculated by Bohr's equation. Dead space is equal to VT, that is tidal volume, into partial pressure of carbon dioxide in the alveolar air minus partial pressure of carbon dioxide in the expired air divided by partial pressure of carbon dioxide in the alveolar air. This comes as an image calculation based question. And your anatomical dead space can be obtained by this graph also, or by a method which is called a single breath nitrogen technique. Single breath nitrogen technique, that is the Fowler's method. Okay, the Fowler's method. You give 100% pure oxygen to the patient to breathe, and when he expires out, the first part which is going to come purely from the trachea, which is the conducting zone, this will have no nitrogen. क्यों? क्योंकि हमने nitrogen तो breathe ही नहीं किया ना, we did not breathe mixed air. I mean the air which is mixture of oxygen, carbon dioxide and nitrogen. What we breathed was 100% pure oxygen. So the first part of the expired air will have only oxygen, no nitrogen. But gradually as the air will start coming from inside, that means जैसे जैसे वो dead space से नीचे अंदर alveoli से आता जाएगा, the nitrogen concentration will rise. So this is the plateau where there is maximum nitrogen concentration. This is by forceful expiration where you can calculate the closing volume and the residual volume. Now what is the clinical relevance? Remember, physiological dead space can increase in conditions when there is ventilation perfusion mismatch. For example, in pulmonary embolism, when there is reduced in the blood flow to the ventilated alveoli, or emphysema, when there is alveolar destruction, which reduces your oxygenation. Now, shock, maybe there is a systemic perfusion reduction, and that can also result in alveolar dead space. Now, which of the following is called as the window of the limbic system? Hypothalamus, amygdala, hippocampus, or thalamus? So the correct answer is amygdala is supposed to be the window of the limbic system. Now, amygdala is very, very important. Now see, suppose there is fire. Okay, there is fire. You will see that there is fire and you will react in different way. Some person may put water over it. Some may call a fire brigade. Some may run away. So the cognition, the affection is different in different persons. Okay, now all this is interpreted to bring about an emotional response, that is fear, anxiety, or whatever, and a skeletal or a somatic response. Now all these responses, obviously they are very, very critical in processing emotions like fear, anxiety, pleasure. So there is somebody which connects everything, which is supposed to be the window of the limbic system, as if you open your window and you are looking outside to the weather. So therefore amygdala is called as the window of the limbic system. What does it do? It helps to mediate emotional responses and has direct connections with other parts of the limbic system, especially your hypothalamus and hippocampus, and they all are important in regulating emotional behavior and memory functions. Now see, this is what is the limbic system. A rim which is present towards the base of the brain. It includes cingulate gyrus. Very important is this para-olfactory area, orbitofrontal cortex. These are associated with olfactory pathways. Amygdala, which is the window of the limbic system. Hippocampus, which is responsible to convert the short-term memory into long-term memory, that is consolidation. Hypothalamus is a very, very important center, and this is, hypothalamus being a part of the limbic system. It has also got centers for sympathetic and parasympathetic, and now you can correlate that how these all work together. Whenever there is an emotional response, there is also secretion of hormones. Anterior nucleus of thalamus is a part of limbic system. This is an important MCQ. And basal ganglia, because the portion of basal ganglia is a part of limbic system, you will get a mask-like face in Parkinson's. Okay, so amygdala, emotional processing, hypothalamus, regulates the autonomic nervous system, the endocrine responses which are there because of the, as a part of the emotional experience. Hippocampus in memory, thalamus relay center. So limbic system is a very, very important area. Now this is something very important which is called as the Pepys circuit. Pepys circuit is very important in EEG, in sleep, emotions. It includes a circuit between the cingulate gyrus, hippocampus, mammillary bodies of the hypothalamus and the anterior nucleus of thalamus. So this also is a very important MCQ. Now, cerebral blood flow is regulated by all of the following except blood pressure, arterial PCO2, potassiums, or A and C, that is blood pressure and potassium ions. So the correct answer is that it is not regulated by potassium ions. Okay, it is not regulated by potassium ions. The main reason is that blood-brain barrier is not very freely permeable to potassium ions and therefore they do not influence the cerebral blood flow. Cerebral blood flow also shows autoregulation. Okay, it shows autoregulation. That means despite of fluctuations in the systemic blood pressure, it still maintains a consistent perfusion. One of the very, very potent regulator of the cerebral blood flow is carbon dioxide. Increase in the carbon dioxide, for example, increase in metabolism results in vasodilatation and increase in the blood flow, and decrease causes vasoconstriction. Hypoxia again causes increase in the coronary blood flow, in the cerebral blood flow, even in the coronary blood flow. And just one consideration over here, hypoxia causes vasodilatation in every circulation except pulmonary circulation. So classically, hypoxia in pulmonary circulation is going to cause vasoconstriction, which is favorable because it redirects the blood flow to the better ventilated alveoli, so that the ventilation perfusion mismatch do not occur. Now, beta 2 receptors act via secondary messengers. Which of the following secondary messengers? Adenylate cyclase, tyrosine kinase receptors, transforming growth factor beta receptors, or cytokine receptors? This is again a very important question that is associated with endocrines and with the second messengers or the mechanism of action of endocrines. So the correct answer is adenylate cyclase. Now, beta 2 receptors are a type of G protein receptors, G protein coupled receptors. Remember, G protein, which is a serpentine or a 7 transmembrane, 1, 2, 3, 4, 5, 6 and a 7 7 transmembrane spanning protein receptor. It exists in two forms. When the hormone is not bounded, it is supposed to be in inactive way, or it is inactive, and as the hormone binds, it becomes active. Again, it can be GS, that means stimulatory, or it can be GI, that means inhibitory. Okay. Now, when there is activation, it is going to increase the conversion of ATP to cyclic AMP. The cyclic AMP then behaves as a second messenger. Okay, cyclic AMP then behaves as a second messenger and activates various enzymes, for example, protein kinase A, which will then bring about the cellular effect. See, so when the hormone is not bounded, it is inactive. In the inactive form, what is present is GDP, and alpha, beta, gamma are all present together. Okay, they are present together. As the hormone will bind to the receptor, the G protein gets activated. Alpha will dissociate from beta and gamma. Alpha will dissociate from beta and gamma, and this alpha, यहाँ पर GDP will be replaced by GTP. GDP will be replaced by GTP, which will result in now activation of adenyl cyclase and producing second messenger, that is cyclic AMP, to bring about the other cellular effect. Now this is adenyl cyclase mechanism. There can also be phospholipase. तो जब phospholipase होता है, right? When there is phospholipase, what is present is GQ. Okay, GQ. Again, GDP and GTP will remain the same. But when phospholipase is present, the secondary messengers would be IP3DAG, diacylglycerol inositol triphosphate, and increase in intracellular calcium, and the enzyme that will be increased will be protein kinase C. Okay, so you must remember the hormones which are using cyclic AMP, or which are using adenyl cyclase, or which are using this protein phospholipase. So tyrosine kinase receptors, they are primarily involved in growth factor signaling. So growth hormone, it is using basically tyrosine kinase. Transforming growth factor beta are again serine threonine kinase and not cyclic AMP or adenyl cyclase. Cytokine receptors, JAK-STAT pathway, right? Now next is a child presented with dehydration, supplemented with ORS solution for management. Which of the following receptor helps in the absorption of glucose? Now glucose absorption is one of the very favorite question. Options: SGLT1, 2 or GLUT1, 2. And what are we speaking about? Kidney, or whether we are speaking about GIT? That is also very important. Now see, glucose reabsorption includes SGLT1 and SGLT2. Also GLUTs. Various GLUTs are there. Out of this, SGLT1 and 2, 1 is present in GIT, and therefore the correct answer over here becomes 1. 2 is present in the PCT, that is the proximal convoluted tubule of the kidney. These SGLT1 and 2 are examples of secondary coactive transport mechanisms. That means they are examples of energy consuming, or they are active transport. They are using energy. GLUTs are example of facilitated diffusion. GLUTs are example of facilitated diffusion. Now, there are many GLUTs. Okay, insulin is not going to act on each and every GLUT. Insulin dependent GLUT is only GLUT4. Okay, insulin dependent GLUT is only GLUT4. See, one intestine and kidney. So mainly one intestine, two kidney. Now, yes, see, the various GLUTs are present, out of which GLUT4 is supposed to be insulin stimulated or insulin dependent, which is present especially in the skeletal muscle, cardiac muscle, adipose tissue, right? So this leads to few more questions, that is, insulin increases the glucose uptake in which tissues? It increases in liver, skeletal muscles, and to some extent cardiac muscles, and is adipose tissue. That means GIT, that means kidney, RBC, brain, all these areas where the glucose is taken up and utilized is not under the control of insulin. So यहाँ पर no insulin is needed. No insulin is needed. Got it? Now just give me 2 minutes so that I can, take out the other PPT. Just 1 minute. Just give me some time, 2 minutes, so that I can just put on the next PPT. Okay, so just with certain few more MCQs. Now, which of the following which of the following taste buds do not which tongue papillae do not have taste buds? You know that taste का जो है is the function of the taste buds. Fungiform, filiform, circumvallate, or foliate, and you will be surprised that these are PYQs. So the correct answer is filiform. Okay, so the filiform do not have taste buds, right? What are fungiform papillae? They are mushroom shaped papillae which are scattered across the surface of the tongue, especially at the tip and the sides, and they contain taste buds that detect sweet, salt, and sour flavors, and also involved in touch apart from taste. Filiform, they mainly have got function in texture. Okay, so they do not have the taste buds. Whereas circumvallate, they are located at the back of the tongue, and remember that they are more in the young age as compared to the age as the age advances. Foliate papillae, they are located on the tongue. The foliate papillae, they basically occur as ridges, and they are more responsive to sour and salt taste. Now, something very important, you know that you had 5 primary taste. You also added umami in the primary taste. The 6th is oleogustus. Oleo means something related to oil. That means an unpleasant taste as if a rancid butter evoked by short chain fatty acids. So it is something which is protective or which protects you from eating harmful. So this is the taste pathway. You must remember that the ventral posteromedial nucleus of the thalamus is involved. So this comes as a very important MCQ to us. The taste sensations from the anterior 2/3 of the tongue is carried by the 7th nerve, and the posterior 1/3 is from the 9th, and still the tonsillar pillars and pharynx by the 10th nerve, that is vagus. Now, sour taste is mediated by which of the receptor? T1, R1, T1, R2, T1, R3, or whether it's TRPP3. Now, these are the transient receptor potential channels. So, TRPP3 sour taste is opened or mediated by ion channels, that is ionotropic, rather than G protein. So those that use G protein are metabotropic, and those who open ion channels are ionotropic. The ionotropic act fast as compared to metabotropic. Ion वाले होते basically sour, ठीक है, but sweet, umami, they are G protein or metabotropic. These are helpful in detecting sour taste, and the sour taste is because of the presence of protons, that is the H+ ions. Now, same type of question which we've already done, so we will not put much time over it. So this shows you the importance of the topics which come repeatedly. Roughness, sustained pressure, Merkel, slow vibration, Meissner's, stretch or Pacinian, fast vibration. So now we know that the Pacinian are responsible for the fast vibration. Now, yes, a patient is experiencing phantom limb pain after the amputation of the right limb. What is observed on the PET scan in a patient with phantom limb pain? Options: expansion of somatosensory fibers for the hand into neighboring areas of the somatosensory area extending into the right hand area, expansion of the right sensory cortex, or expansion of the left sensory cortex. So the correct answer is B, that is the neighboring fibers of the somatosensory area, they extend into the right hand. You explain this by something: phantom limb pain which occurs after amputation of the limb. This is according to the sensory law, that is the law of projection. Okay, it is the sensory law, that is the law of projection. Okay, so when there is amputation of the limb and it is thought that there is some reorganization in the brain, especially in the somatosensory cortex. The brain's somatosensory cortex has specific regions which are dedicated to different parts of the body. So when the limb is amputated, the corresponding area in the semisensory cortex is devoid of its input. But due to this, the neighboring areas in the somatosensory cortex, they extend their fibers to the previously occupied by the missing limb. So the law of projection contributes to this. So phantom limb. Weber-Fechner's law is that the sensation felt is directly proportional to the log of intensity of stimulus. Other important laws are the Bell-Megendy law that says that in spinal cord, the dorsal roots are sensory and the ventral roots are motor. Then labeled line principle, it goes same as the Muller's law or the doctrine of specific nerve energies. that refers to the specificity of the nerve fiber to carry only one type of modality. Muller's law also is the same, reflecting the specificity of the pathway and also the cortical area which gets stimulated. That means if the cortical touch area gets connected with the skin temperature receptor, then the temperature stimulus either will be not recognized or it will be recognized as touch. So not only the specificity of pathway but also the specificity of the cortical area that is getting stimulated. So these are very important, and यहाँ पर you really repeatedly you get MCQs on these questions. Now caffeine, yeah,
रीडिंग शिफ्ट में डिफिकल्ट आएगा.
हाँ. Caffeine impairs sleep by which of the following mechanisms? It blocks adenosine and promotes wakefulness. It activates the locus ceruleus. It activates the locus ceruleus and promotes wakefulness. It has no role in maintaining wakefulness or activates histamine and prevents sleep. So the correct answer is A, that is it blocks adenosine and promotes wakefulness. Now you know that caffeine is widely used as a stimulant that affects the central nervous system by reducing sleep and producing wakefulness. It primarily brings about this by blocking the action of adenosine, and adenosine is basically a neurotransmitter that promotes sleep and relaxation. Adenosine levels gradually build up in the brain during the waking hours, and by blocking the adenosine receptors, caffeine prevents its sleep promoting action and thus helps in keeping the individual awake and alert. Now, which ion is responsible for the resting membrane potential? Obviously, without doubt, it is going to be potassium. What is the reason for this? There are leaky channels. Okay, leaky channels, they increase the diffusion of ions across the membrane. So they are not dependent upon any voltage or upon any ligand. These leaky channels are maximally permeable to potassium, right? And therefore potassium becomes the most diffusible ion at rest. Most diffusible ion at rest, and that is the reason that why potassium, because of its selective permeability, plays a very important role in resting membrane potential, and therefore we say that the resting membrane potential is close to the equilibrium potential of potassium ions. The basic reason is the permeability of the potassium ions, which is maximum. Sodium ions have got a role in depolarization. They are never leaky, right? So the resting membrane potential, or which is more equal to the equilibrium potentials. So the equilibrium potential of potassium is between -90 to -94 millivolt. That of sodium between +61 to +65. These are the Nernst potential or the equilibrium potential of ions. That for calcium is +132 and for chloride is between -70. Now, what is the sequence of events in neuromuscular action potential? Remember what will happen when you speak about this neuromuscular junction. Okay, so what are the events that are going to take place when we consider the neuromuscular junction? Sodium channels open in the end plate. Calcium enters and release of acetylcholine. Now, when the action potential travels, first thing is the opening of the voltage gated calcium channels. Okay, so opening of the voltage gated calcium channels. These calcium ions will then help in the release of acetylcholine from the secretory vesicles. This acetylcholine will then act on its nicotinic cholinergic receptors, which are located on the muscle end plate, which will then create the end plate potential and convert it into an action potential. Therefore, the correct sequence becomes 2, 3, 1. Okay, 2, 3, 1. That is calcium, then sodium, and then acetylcholine. Now, a woman suffered from sunburn while enjoying a vacation on the beach. Now she's taking a shower with a lukewarm water that is around 40 degrees Celsius touching her back, and that is causing her pain. So lukewarm water is causing her pain. That means the stimuli is not painful. It is not a painful stimuli. It is a non-painful stimuli but leading to pain. Okay, so understand nicely. What type of receptors were activated by the lukewarm water and why did she experience pain? So, the women experienced pain from a non-painful stimuli. From a non-painful stimuli which is called as allodynia. So, which is pain for a non-painful stimuli, that is lukewarm water. Sunburn already has led to inflammation and sensitization of the skin, which has increased the sensitivity even to mild stimuli, and therefore the receptors got activated by lukewarm water, which are innocuous thermal receptors, which typically detect non-painful stimuli like normal skin temperature changes, and therefore the correct answer is D, that is innocuous thermal receptors and allodynia, that means pain to a non-painful sensation. Now, what contributes to zero phase of action potential in the SA node? So, in the SA node and in the cardiac ventricle action potential, what is the difference? See, this is 0. That is depolarization, phase 1, that is initial rapid repolarization, phase 2, that is plateau, phase 3, that is final repolarization, and RMP, this is the cardiac action potential in the ventricles, right? So depolarization is because of sodium influx. Very good, Tushar, very good. Initial rapid repolarization, transient potassium channels, plateau calcium, and final repolarization again by potassium. In the SA node potential, you get only 0 and 3 phase. That means you get only depolarization and repolarization. Okay? That means 1 and 2 are absent in the SA node. Very, very interestingly, depolarization in the SA node is because of not sodium. It is because of calcium. This is very, very important consideration, that the 0 phase, that is the depolarization in the SA node, is because of calcium. Similarly, the depolarization in the smooth muscles, for example GIT, is because of calcium and not sodium. Elsewhere you get sodium, but yahan par you get calcium. Next, regarding the entry of glucose, which organ or tissue demonstrates insulin dependent? So already we've discussed insulin dependent glucose is only seen in adipose tissue, basically in adipose tissue, in hepatocytes. Okay, you get it in, sorry, regarding the entry of glucose, which organ or tissue demonstrates insulin dependent glucose uptake? So insulin dependent glucose uptake is adipose tissue, skeletal muscles and liver. Okay, so the best option is adipose tissue because it is using GLUT. In the liver also, okay, in the liver also insulin stimulates the glucose uptake, but it is not through glucose through GLUT, but it is by increasing the activity of enzyme hexokinase. Now, which is primarily responsible, or what is the primary mechanism by which PTH increases the blood calcium level? Increase renal reabsorption of calcium, stimulation of osteoclastic activity, or stimulation of vitamin D. So all are true. PTH primarily is increased whenever there is a decrease in the level of calcium. It will first result in increase in the formation of active form of vitamin D, which takes place in the PCT of kidney. It will then also increase the reabsorption via kidneys and resorption from bone. So these are the direct actions, that is resorption. Now this vitamin D, which is increased as a result of PTH, will then increase the reabsorption of calcium from the intestine by also stimulating a calcium binding protein that is called as calbindin. So therefore calcium reabsorption in the GIT is the indirect effect of PTH. Yes, correct, Tushar. Now, the diagram displays nerve cell physiology. Identify the events from 3 to 4. 1 minute. From 3 to 4. So we already know that 3 to 4 is repolarization. That is going to be because of potassium efflux, that is potassium exiting. So remember that whenever there is an image based diagram, you may get a bit confused, but think logically and then look into the options. So repolarization. Now this stage is called as after hyper repolarization, that is contributing to more negativity than RMP. That is mainly because of the continued efflux of potassium ions. As you know that the potassium ions are passing out or in through the voltage gated potassium channels, which are slow to open and slow to close. Motor supply of muscle spindle. Now remember, we are telling about motor supply of muscle spindle because muscle spindle has got both motor and sensory. So it is gamma. Now this is the skeletal muscle, which is called as extrafusal muscle fiber, having motor supply A alpha or the alpha motor neurons. Inside this you have got intrafusal muscle fiber, which is your muscle spindle supplied by gamma motor neurons, and this is the stretch sensitive receptor. So skeletal muscle, extrafusal, and inside the skeletal muscle, muscle spindle, which is intrafusal and supplied by gamma motor neurons. It has got sensory afferents 1A and 2, and 1A is responsible for your stretch reflex. Okay, so with this we end today's session, and we will be continuing or having more of these sessions. I will be sharing all these PPTs and PDF to you, so don't worry about that, right? So beta motor neurons and delta fibers in pain and temperature. So that's all for today. Thank you and happy learning.